Good evening, all. You are welcome to the third lecture on basic laparoscopic course. And today we are going to continue with the classification of laparoscopic instruments. In our last lecture, we talked on the imaging system. Today, we are going to continue with other laparoscopic device to complete the classification. Now, we broadly classify the instruments into imaging devices, exposure and manipulation equipment or instruments, then hand instruments. Now, for the exposure and manipulation equipment, they include the insufflator, the carbon dioxide insufflator, to create the room for visualization of the abdominal cavity so that the procedure can take place. While the irrigation, the suction irrigation system is a system that introduces fluid to irrigate contamination and suck out collections to make the operating field clear, because this is a very important aspect, because without clarity of the operating field, the operation will be impossible or completely difficult. Then the hand instrument. The hand instruments are the working device, the working instruments that are used for both manipulation and the procedure itself. Today, we are not going to talk about the energy source, because this is a very important aspect that requires a discussion, a separate discussion, because energy devices in laparoscopic procedure is a very important aspect that requires a session, a single session, to understand the concept behind it. So today we'll talk about insufflator irrigation, suction irrigation system, and the hand instrument or the working instruments. These working instruments are very, very important for you to be able to identify and differentiate them. Now, the electronic insufflator or carbon dioxide insufflator is an automated device that is used to inflate carbon dioxide into the peritoneal cavity. You can see the machine as shown on this slide. It has a section where a port that delivers carbon dioxide onto a tubing, and that tubing will deliver the carbon dioxide to the access point on the abdomen, where it is delivered into the cavity. Okay, the carbon dioxide is the preferred gas because it is not combustible. That is, it does not support combustion. Even if there is any item that will cause spark, or if burning, the carbon dioxide is going to, combustion requires oxygen, and carbon dioxide is used to quench off all sparks and flame. So it is a non-flammable gas. That's why it is the preferred gas. If you use a flammable gas as an insufflation gas, when you introduce any energy device, there's going to be spark and it will cause explosion. So carbon dioxide is the gas that is used as the insufflator to expand the abdominal cavity for visualization. Now, recording in progress. If you look at the machine, you will notice it has a pressure gauge, a flow rate, as well as a set pressure, then the volume of carbon dioxide to be delivered. There are different companies with different types of machine. Okay, the machine is designed to auto-regulate according to a preset parameter. Now, if you are to insufflate carbon dioxide into the peritoneal cavity, before you do that, you have to preset a pressure. Preset pressure is the pressure that the insufflation cannot exceed, because you know, if it exceeds certain pressure, the intra-abdominal pressure will increase and this will affect organ function. It will compress on major vessels, inferior vena cava, venous return will reduce. It will compress on the kidneys, the liver, and even on the heart. So you need a preset pressure that will maintain exposure as well as maintaining normal homeostasis. Usually we preset a pressure between 12 to 15 millimeters of mercury as a preset pressure. It means that machine will not insufflate beyond that preset. If it is 12, as it gets to 12, it will auto-regulate and stop. Okay, it consists of quadromanometric indicators, the preset pressure as we mentioned, the actual pressure of gas delivered will also be shown on the machine. Then the flow rate of carbon dioxide. You have to set a flow rate because you don't want the gas to flow so rapidly, because if it is flowing so rapidly, it will cause carbon dioxide gas embolism. So you want to maintain a low flow of 1 to 2 millimeters of mercury. You don't want to exceed 2 millimeters of mercury. And the machine will also show the total volume of carbon dioxide that is delivered. So this insufflator, the pressure is normally preset at 12 to 15, as we mentioned, and the flow rate of 1 to 2 millimeters of mercury. Okay, so the device, it supplies gas until the required intra-abdominal pressure is reached. It activates and delivers gas automatically when the intra-abdominal pressure falls because of gas escape or leakage from the port. Now, during the procedure, if you are losing gas for any reason, the machine will automatically detect the loss of pressure, and at the same time, it will now deliver carbon dioxide. Don't forget, the carbon dioxide insufflator is connected to a carbon dioxide cylinder. Most of the time you see the cylinder silver, it is painted silver color. You know, most of the cylinders are color coded. So carbon dioxide cylinder is usually painted silver color. So now the carbon dioxide cylinder will have a gauge like this that will show both the quantity of carbon dioxide in the cylinder as well as the pressure within it. But However, newer insufflator devices will show the amount of carbon dioxide in the cylinder, whether it is full, medium, low, or even empty. And it will even show the pressure within it. So newer devices may not require a gauge attached to the cylinder. So newer models insufflator are designed to warm carbon dioxide before insufflating the peritoneal cavity, thus reducing heat loss and fogging of the lens of your telescope. Now, if you look at this machine, you will see it even have a probe for temperature. This is where the tubing is connected. This is where the tubing is connected to deliver gas to the ports that are placed into the access points. Okay, so you have to be conversant with the machine and know that anytime you see a carbon dioxide insufflator, there are 4 parameters you are looking at. 1, the preset temperature. 2, the actual pressure of the gas that is delivered. Then the flow rate is very important, because if it is high, there is risk of gas embolization. Then the total volume of gas that is delivered. Now, carbon dioxide insufflation, there may be complications of gas embolism, as we mentioned, gastric reflux following increased intra-abdominal pressure. Sometimes that's why we usually you need to pass NG tube sometimes to empty the stomach, because patient might have reflux and post-operatively they might even be having heartburn. Okay, so you pass NG tube, empty the stomach. 1, it will give you more room to manipulate if you are working in the upper abdomen, for example, a gallbladder surgery, and also it will prevent this reflux that will be causing heartburns. So, effect of increased pressure on the heart, renal, liver function, and extraperitoneal gas insufflation. Now, you should know that sometimes if these ports are not in the peritoneal cavity, they are placed in the subcutaneous space, and you start delivering gas, you have widespread subcutaneous emphysema. So you have to be very careful, because that could be very dangerous by just placing the pots and it's not in the peritoneal cavity yet, and you start insufflating gas. You blot the patient with subcutaneous emphysema. Okay, these are some of the complications that are associated with the carbon dioxide insufflation. Now, the suction irrigation. Now, the suction irrigation system, there is a specialized machine that delivers irrigation fluid and suction fluid at the same time. Now, if the machine, there could be 2 types actually. There is a machine that has both an inbuilt suction and irrigation system. And there's a machine that has only an irrigation system. Then you need a suction machine to be attached to the tip of the probe. Now, there's a connecting tube that connects to the probe. This is the probe, okay? And if you look at this probe, it has 2 outlets, or it has an outlet for irrigation fluid, for sucking out the fluid. It has inlet for letting in irrigation fluid. while the outlet is for sucking out. Then it has a tip that is introduced into the peritoneal cavity. And this knob, when you move it forward, it is for delivering fluid into the peritoneal cavity. If you leave it at a neutral position, it is neutral, neither irrigating nor sucking fluid. While if you take it backward towards you, it will suck the fluid in the peritoneal cavity. Now, this port could either be, the probes could either be 5 or 10 millimeter probe, depending on the port you want to introduce it to and the quantity of fluid you want to suction. Now, if you look at this suction irrigation device, this is a suction irrigation device that has both the irrigation system as well as the suction system inbuilt. This is a very good machine because for this, you don't need a separate suction machine because it is inbuilt. So you just preset the pressure for both suctioning and the pressure for irrigation. Okay. Now, if you look at the tip of the suction tip, this is the suction tip. You can see some nozzles and the tip has a bigger opening. Now, normal saline, Ringer's lactate or heparinized saline are solutions used to clear the operation field of blood and fluid collection. The tip of the suction probe is dipped directly into the blood or collection before activating, as it can frustrate the operative process due to gas depletion. Don't forget, you insufflate the peritoneal cavity with gas. As you suck out, it can suck the gas along the fluid you are sucking. So if you want to suction a fluid from the peritoneal cavity, make sure the suction tip is within the fluid before you activate the suction nozzle. That is this suction nozzle has a button, but the other common one we use has a knob that when you pull it towards you, you are sucking out the fluid. If you push it forward, you are irrigating with fluid, and if it's at the middle, at the neutral position. Okay? So, if there is presence of blood clots, or more than 1,500 mils of hemoperitoneum, it is advisable to use the 10 millimeter size probe. It has a bigger caliber lumen and it sucks and it won't get blocked by the clot. If you have less than that, you can use the smaller caliber suction probe. The tube can be used for blunt dissection. That suction tube you are seeing, that is the tip. You can use it for blunt dissection during the procedure. Blood is the darkest color inside abdominal cavity, and excess blood inside absorbs most of the light. When you are operating and if there is bleeding, you have poor vision. The light will not be bright because the blood will be absorbing the light. So you have a very dark operation field. So it is very important you irrigate properly and then you suck out the fluid. And this is very effective, especially if you have a very good device and the pressure can be set for the amount of flow you desire. Now, if you look at this slide, this is the probe, as we mentioned. It is this end that is attached to the suction tip, either a 5 millimeter or a 10 millimeter. Now, the head or the nozzle of this tip are universal. whether it is a 5 millimeter caliber or 10 millimeter caliber, it will fit into the suction nozzle. Okay, now this knob here, when you push it in this direction, as we mentioned, is for irrigation, and if you take it backward, it's for suction. If you leave it at the middle, it's neutral. And this is where the irrigation fluid is connected, the tube from the machine. This is an irrigation machine, okay? And this is where the suction tube is connected. If you have this type of machine, rather than the other type we showed that has inbuilt suction and irrigation, you need a separate suction device. Okay, if you have this type of machine, that means you need a suction machine, and the tubing from the suction machine will be connected to this point, while the tubing for the irrigation from the irrigation will be connected to this point, and the tip, the suction tip, will be attached to this nozzle that will enter into the pot. And this knob, if you push it forward, don't forget, you instill irrigation fluid into the peritoneal cavity. If you push it backward, you suck the irrigation fluid. And don't forget, for you to suck, the tip should be inside the fluid so that you do not suck out the gas and causing frustration during the procedure. Now, we'll talk about hand instruments. Laparoscopic working instrument can be disposable or reusable. Reusable instruments are expensive initially, but in the long run, they are cost effective because you sterilize them and use them severally. The cost of disposable instrument is less, but the patient cost is more, because if you are preparing a patient for laparoscopic surgery and you are using disposable pots, the cost of that pot will be incorporated into the patient's cost, even though it is more advantageous because of sterility. You don't have to be sterilizing reusable, but it's the patient incur more cost. The advantage of disposable instrument is high performance due to its sharpness, reduced chance of disease transmission due to certified high-end factory sterilization. Now, we are going to talk about some of the instruments we use. The first one we'll talk about is the Veress needle. The Veress needle, as we mentioned, devices could either be reusable, which are metallic, or plastic. This device is used to achieve initial access for pneumoperitoneum before introduction of the trocar. Now, we are going to discuss access in laparoscopic surgery. The access could either be closed access or open access. Closed access, you are not making incision to open the peritoneal cavity before introducing your pot. Rather, you use the Veress needle through a pinhole incision. It is inserted and insufflated. And when you achieve a pneumoperitoneum, then you will now insert your trocars. Okay, so the Veress needle is the device that is used to achieve that initial pneumoperitoneum. This part is the part that is introduced into the peritoneal cavity, and this is the part that the insufflator tube is connected, and it delivers carbon dioxide into the peritoneal cavity. As you can see, there's a knob here that will let in carbon dioxide or lock in to prevent inflow of carbon dioxide. Now, it consists of an outer beveled tip, okay, cannula for cutting through tissues. Okay, if you look at the Veress needle, it has an outer sheet, okay, or the outer beveled cannula that is sharp, just like your normal cannula, okay, that cuts through the tissue, and an inner spring-loaded blunt tip, okay, stylet to prevent visceral injury. Now, the inner stylet is blunt, okay, and it is spring. So when it touches a tissue, it springs in to prevent injury, and it is blunt. So the Veress needle has an outer sheet that is the cannula and the inner stylet, okay? So the inner stylet has a lateral hole towards the tip for intraperitoneal carbon dioxide delivery. So now if you look at this tip, there's a hole there through which the carbon dioxide is delivered into the peritoneal cavity. The needle comes in different lengths, sizes. 80 millimeters for teen patients, 100 millimeters for normal patients, and 120 millimeters for obese patients. A test for patency and spring action are advisable before using it. Now, you must ensure that this is patent before introducing it, and you also confirm the presence of the needle in the peritoneal cavity before insufflating carbon dioxide. We are going to demonstrate how to confirm that. Now, this instrument is held like a dart. It's held like a dart with the needle held with the thumb and the index finger when in use. And you can see how it is placed at 45 degrees on the anterior abdominal wall, the umbilicus pointing towards the bladder or pointing towards the pelvis to prevent direct injury on abdominal viscera or blood vessels. So remember, it is held like a dart with the index between the index and the little finger. Now, when this Veress needle is introduced, the signs that confirms correct intraperitoneal placement, you feel two separate gives, okay? Two separate give sounds on penetrating the single rectus sheath at the umbilicus and the peritoneum. Now you hear hissing sound, indicates negative pressure, okay? Negative intraperitoneal pressure suction. There's what we call the hanging drop test, where a suction pressure and manometric test is done. Or you see, this image describes a more practical way to confirm the presence of your Veress needle in the peritoneal cavity. If you look at aspiration test, A, when it is inside, a positive result, aspiration of fluid or tissue. A negative result, okay, material is aspirated. So you get a syringe and instill fluid into the opening of that syringe of the Veress needle. So if it is in the peritoneal cavity, of course, you know it will pass smoothly into the peritoneal cavity, and you cannot recover your fluid, okay? But if you are recovering the fluid, it means that fluid is not entering the peritoneal cavity. Or when you drop a fluid in the opening of the Veress needle, it doesn't goes in, it flows back. So that indicates that it's not in the peritoneal cavity. Now, you should know most surgeons prefer to do the open method by making an incision in the abdominal cavity on the anterior abdominal wall before introducing the ports. They introduce the port under vision because these instruments tend to be risky, okay? In an unskilled hands, vascular injury, gas embolization, and intraperitoneal visceral injury are common. So that's why you see most surgeons prefer to make an initial incision and insert their port under vision. Then they now anchor the port. But in a very good hands, this method is also a very recommended method of access into the peritoneal cavity. Now, that is about the various needles. So we'll talk about trocars and cannulas. A trocar is an appliance passed through the anterior abdominal wall in laparoscopic surgery via a small incision. This acts as a port as other instruments are passed through to perform laparoscopic procedure. So if you are doing an open access where you don't want to use the varus needle, you just make a small incision above, below, or through the umbilicus and introduce your trocar and cannula through that incision under direct vision. These have less tendency for injury to intra-abdominal viscera. Now, when the inner obturator is removed, it serves now as a port for introducing your camera and other instruments. Now, the parts, it has, what are the parts of the laparoscopic ports or cannula, trocar and cannula? It has a trocar obturator, which is the inner sheet. This obturator could have either a blunt or a sharp tip. The obturator could have a blunt or a sharp tip. Now, it has a cannula, the outer sheet. This cannula port is called the outer sheet, through which the obturator is passed. Now, when the obturator and the port or the cannula is introduced, the obturator is removed, leaving the cannula behind, serving as a port for introduction of other instruments into the peritoneal cavity. Now you can see the grip screw sleeve where you use this instrument to reduce the size of the cannula port if you are using a smaller instrument. The trocar has three components: the hollow port, which is the outer cannula, an obturator, which is the inner trocar. Then you have a flap valve. The flap valve, there is a valve that ensures unidirectional flow of carbon dioxide into the peritoneal cavity. If this valve is faulty, you have leakage of carbon dioxide and the abdomen will be collapsing and the surgery will be frustrating. And of course, you have a very lengthy procedure. So you must ensure you have a very good port. The cannula varies in size, with diameter ranging from 3 millimeters to 30 millimeters, though the commonly used are 5, 10, and 15 millimeter ports, commonly 5 and 10. The 5 millimeter is used to introduce hand instruments. the 10 millimeter for laparoscope, and 15 millimeter may be used for introduction of larger instrument like mesh fixator for ventral hernia repair. Usually, during laparoscopic surgery, the first port you introduce is the optical port. That is the port for the laparoscope or the telescope, which is introduced through the umbilicus, above the umbilicus or below the umbilicus, and that is usually the 10 millimeter port. Now, you should know that newer ports allow passage of instruments of different sizes without leakage. The newer, especially the disposable plastic ports, irrespective of the diameter or the caliber of the port, you can either pass a smaller instrument, 5 millimeter, through a 10 millimeter port without leakage, and you, of course, the normal 10 millimeter through a 10 millimeter port. Now, if you look at the metallic type here, you see the valve. This valve of the cannula, flap valve, prevents backward flow. Then the outermost parts at the rim of the cannula has sealing cap that also prevents leakage. Then there's an insufflation valve inside, and there's a knob here that either switch on or off the flow of carbon dioxide into the port. The sharp edges of the trocar has a risk of injury to the anterior abdominal wall vessels and internal abdominal viscera. Sometimes after placing the port, if there's a vessel lying there where the port is inserted, you will see bleeding. You might see bleeding coming out from the site of the insertion of that port. So all these are important, you know. But subsequently, we are going to have a physical class for describing all these instruments. You appreciate them better when you see the instrument and handle them and look at all the parts. The working instruments or the hand instruments now could either be grasping instruments, which will include graspers, okay, either crushing or non-crushing, okay, for grasping soft tissues or for grasping tough tissue like the Alice. Then the dissecting instruments. There are instruments that are used for dissection, like the Maryland forceps, the L-hook dissector, and so on. Then the laparoscopic scissors. There are different types of scissors, which could either be a curved scissors, a straight scissors, or a hook scissors. Then there are tissue approximation tools, like the needle holder, okay, for applying sutures. There is also the clip applicator. Then there are some miscellaneous instruments like the knot pusher. Use it when you form an extracorporeal knot. The extracorporeal meaning the knot is formed outside the cavity, and you now use a knot pusher to push the knot into the peritoneal cavity and form a tie there. There could be an aspiration needle, needle introducer, reducer, morcellator, insulation tester, and also a retrieval bag. Now, the typical shape of an instrument is having a handle. It has a handle. It has a shaft. Then it has a tip or tissue end. That is a typical structure of the laparoscopic hand instrument. Now, the hand instrument, the handle, this is the handle. This handle has a finger bow here, where your finger enter the thumb and the and the middle finger or the ring finger. Then you have the ratchets. This is the ratchet for lock. You can lock the handle so that the tip holding the tissue is secured. It can't be manipulated. So that is the handle of the instrument. It could be ratcheted or non-ratcheted. The handle could also have a tip for attaching energy device, either a monopolar device or a bipolar device, so that the tip or the tissue end will serve as an energy device, just like a diatemy for either coagulating or cutting. So these are the various types of handle. And the handle also has a rotation knob. This knob, when you rotate, it rotates the tip of the instrument such that you align the tip in an orientation you want to pick the tissue you are handling, so that you don't have to be pulling the instrument in and out. Okay, so as you rotate this knob, the tip rotates to the direction or the orientation you want the tip to align and hold the instrument. Now you can see this handle is a handle without a ratchet. Usually these handles without a ratchet is commonly used for instruments like scissors or Maryland for dissection. Because if you are cutting, you don't want a ratcheted handle. You can't be cutting and it's locking and you are unlocking while cutting. Or during dissection, you want it smooth. And they are also either having an energy point or not for attaching a cord to an energy device or a diatemy. Now, this is the shaft of the instrument, and this shaft, you can see this portion is screwed into the rotation knob here, okay, so that it is fixed. Then you have the inner sheet, which is the one carrying the actual tip of the instrument that is used for manipulation. The laparoscopic working instruments are designed for the same purpose as those used in open surgery. So if you know all the instruments for open procedures, the tips are the same as those in laparoscopic surgery. The only difference is just these have a long shaft for introduction through the ports, but the tip of the instrument are the same. If you see a Babcock, it's still a Babcock here. If you see an Alice forceps, it's still the same Alice forceps you know, but taking the shape and design of a laparoscopic hand instrument. They are thin, doubly insulated. You see, that shaft have to be insulated, because if you are transmitting energy, it's going to, without insulation, it's going to burn the tract and it's going to burn the tissue in contact within the viscera. So only that tip is not insulated. So they are thin, doubly insulated shaft that transmits the anterior abdominal wall, connecting the tissue end with the handle held for manipulation outside the peritoneal cavity. The tissue ends are adapted for different purposes, as we mentioned, just like your open instrument. The shaft length is 25 cm for pediatrics, 35 cm for adults, and 45 cm for bariatric procedures. You should know that newer generation instrument can be disassembled for proper cleaning. The older instruments, you cannot disassemble, as we saw that instrument in various parts. They are designed for either monopolar or bipolar energy cable. Now, if you look at the tip of the instrument, that defines what particular instrument you are handling, because this inner sheet, this inner part of the instrument will be introduced into the sheet are locked with the head. It has a screw at the other end of the tip that screw into the handle of the instrument. Now, it is the tip that will now define what type of instrument it is. So during our practical session, you will see how to assemble and disassemble a laparoscopic instrument for proper cleaning. Okay, now this is a laparoscopic bowel grasper. Okay, it could have a racheted handle. Okay, double action. When you say double action, it means both of the blades are moving when you manipulate the handle. Both blades will move. Okay, now it is fenestrated to reduce tension or pressure on the tissue you are grasping. So it's a bowel grasping instrument for grasping and manipulating the bowel. Okay. This is also another tip of a bowel grasping instrument. Laparoscopic Alice grasping forceps. It has a sharp tip for grasping a tough tissue. You could also have another Alice like the normal Alice you used to know, cuff like this. Okay, you can have something like that also. But this is also an Alice forceps. It's usually for grasping a tough tissue. Then the Babcock, laparoscopic Babcock grasping forceps, just like the normal Babcock for grasping bowel or appendix. Okay, this is also a Babcock tip. Now the L-hook electrodes, it has a hook-like tissue end with insufflated shafts, non-racheted monopolar powered needle. This is the hook. It is used for dissection. The mnemonic used here when using the L hook, we say hook, look, and hook. When you hook a tissue to be dissected, because it's diatomy, it's an energy source, it's connected to a diatomy machine. You have to look at what you are hooking, then you now coagulate or cut as the case may be. So you hook, look, and cook for tissue dissection and separation of tissue. This is a very useful instrument, especially if you don't have all the modern energy devices. Now, sometimes the L hook can be connected to a diatomy pencil depending on the size of L hook you have. Some surgeons prefer to use the handheld device, while some prefer to use the other type we showed, using the foot pedal. So if you are using this type, you can use your normal diatomy. So if you are used to the diatomy, you can get a smaller size L hook so that it fits into your diatomy pencil. Now, Maryland, this Maryland tip is a very important instrument in laparoscopic surgery. It is for sharp, it has a sharp tip for grasping tough tissue, and it is used for blunt dissection and separation of planes, dissection of planes. So this is a very, very important instrument, Maryland forceps. You can see the tip has transverse serrations, just like an artery forceps. So you use it for blunt dissection, and you use it for holding tough tissues. When you are suturing, you can also use it with the needle holder for holding the needle, or you can use the grasper. Now the scissors, The laparoscopic scissors could either be straight as shown on this image, it could be curved like the surgeon scissors, or a hook scissors. It's a lightweight dual or single action curve. When we say dual action, when you manipulate the handle, both of the blades will move. When you say a single action, if you manipulate the needle and the handle, only one of the blades will move. Has insulated sharp and non-ratcheted handle. For scissors, scissors are non-ratcheted handle because you are using it for cutting of tissue. Now the biopsy forceps. The biopsy forceps has an oval fenestrated jaw and it's a single action, meaning only one of the blade will move. Okay, it is non-ratcheted handle with rotation knob, lock, and it could also have a monopolar port for insertion of monopolar cable. For tissue biopsy, you can also have a tissue biopsy forceps that has two pins within the blade so that it picks the tissue and the tissue doesn't falls out. For this type of tissue end, when it grabs the tissue, you have less chance of losing that tissue because of these two pins. Now the needle holder, laparoscopic needle holder, the tip will have, it has a stout crisscrossing, like lines with a groove at the tissue end. It's just like the normal needle holder with crisscross serration. It has a ratchet handle for holding a needle. Now, the laparoscopic clip applicator has a curved dual action tout jaw for holding and applying clips. So it could either be reusable where the clips come separately and when the clips are applied in the tip before clipping a tissue, or you have a disposable ones that already have clips within the shaft, and as you keep on using it, the number reduces until it empties. And when you are clipping a tissue with the clip applicator, make sure the two ends are seen. Okay, you must see the other end of the clip before applying. When you now apply pressure on this, apply force on this to clip, so it will now release the clip from this end to clip this tissue. So you must make sure both ends of the clip are seen before clipping the structure, so that you don't clip a vessel halfway and the vessel keeps on bleeding. This is a very important instrument for applying, for clipping vessels, clipping tubular structures. You can use it to secure hemostasis if you have bleeding. So it's generally used for clipping tubular structure. In fact, you can use it for appendectomy also. Now, laparoscopic staplers, just like normal staplers, you use for stapling anastomosis, for anastomosing bowel. You also use for when you do bariatric surgeries. They are very, very useful in bariatric surgeries, colonic surgeries. So it makes your procedures very rapid. Now, laparoscopic knot pusher is for pushing and tightening of knots. When you make an extracorporeal knot outside the peritoneal cavity, it's called extracorporeal knotting. You use the knot pusher. You use this tip to push the knot to the structure you want to ligate. So you introduce the knot will be here, while the loop is here, and the thread will be attached. You hold the thread on this side, outside the cavity. So when it gets to the structure, maybe the appendix, you loop it inside this, then you now use this tip to push the knot to tie the base of the appendix or the structure you want to tie. This is an aspiration needle for aspiration of fluid collection from the cavity or a cyst. Now you have a reducer. This is very important if you want to introduce a smaller instrument through a larger port. By passing an introducer, you reduce the caliber of the port so that it can admit a smaller size instrument, preventing leakage of gas. Because if you pass a smaller size caliber instrument into a larger port, especially for a metallic port, there's going to be a leakage of gas, but the reducer will prevent the leakage of gas. This is a musculator. Now, a musculator, it is used to slice resected solid mass into spiral ribbon-like pieces for easy retrieval. Because after laparoscopic surgery, remember, you have to retrieve the tissue using a retrieval bag. But sometimes if you have a very large tissue that cannot be retrieved through the port, you might need to musculate the tissue into smaller pieces that can be retrieved. Now, it has powered machine and instrument handle, as you can see. It is not advocated for malignancy because if you musculate malignant specimen, you are going to disseminate that malignancy. It has risk for visceral injury. Now, laparoscopic insulation tester, because all these instruments are insulated to prevent, okay, burns of tissue when you are passing an energy through that instrument. So you need an insulation tester that will confirm the integrity of the insulation of that device before using it, or if you have been using it for a long time. So today, we have successfully discussed other instruments like the manipulation instrument, which we said the manipulation instrument include the insufflators and the suction irrigation system. We reserve the energy source because it's a very important section that needs to be dealt with separately. Then we've talked about the hand instrument, that the hand instrument typically have the same structure. What differentiates them is the tip of the instrument, which are the normal, the usual ones you used to know, similar to the instrument for open surgeries. The hand instruments have the handle, which has the finger bow and the ratchets and a rotation knob. It has the sheet, which is an insulated rubber or plastic sheet through which the inner instruments carrying the tissue end at the tip is introduced and locked to the handle. And it is that tip that determines the type of the instrument. So we've come to the end of the lecture for today. If you have any question, any clarification, you can unmute yourself and ask. Thank you very much for participating. Is there any question? So I believe there is no question since the class is quiet. So in the absence of any question, we are going to stop here. Next week, God willing, we are going to complete the classification where we'll discuss on the various types of the energy devices that are used in laparoscopic surgery. So thank you all. Thank you for participating. Okay.